Thank you all for joining us. We'll get started in just a few moments and allow everyone time to join. Thank you all for joining us today. I'll now turn it over to ASH Executive Director, Laurent Hubert.
Thank you, Megan. So welcome everyone to this webinar on the topic of cross-border collaborations to implement interventions that protect the right to health, a right that has been recognized at the highest level of international law through human rights treaties, and a right that is fundamental to the achievement of other rights. So in this case, we will be talking about cross-collaboration between Polish and US smoking cessation experts. And as many of you know already, probably, unfortunately, when we monitor implementation of tobacco control policies around the world, well, we've noticed that cessation is unfortunately one of the most neglected tobacco control policies around the world. So for this reason, this example that you will hear about today of this collaboration between the US and Poland is extremely useful to present best practices that advance progress towards cessation measures. So before I introduce the speakers, some very quick housekeeping issues. You can type questions for the panelists and for the speakers using the Q&A box, and you can use the icon at the bottom of the screen and feel free to direct them to a specific speaker. You can also use the chat function to communicate with the attendees, but some of your questions may be missed. So I really encourage you to use the Q&A icon at the bottom of the screen. So we'll welcome the panelists now. And the first speakers are Magdalena Cedzyńska, who's a psychologist and psychotherapist, senior researcher and director of smoking cessation service at the National Research Institute of Oncology in Poland, and Jennifer Peregoy, who's the tobacco treatment specialist at the University of Virginia Comprehensive Cancer Center. And they will discuss how the UVA, University of Virginia's tobacco treatment program, guides National Research Institute of Oncology in Poland to develop more cessation resources. Magdalena and Jennifer, the floor is yours.
Thank you. Okay, so Welcome, everybody. Good morning. In Poland, it's almost dark outside the window because it's after 4 p.m. I'm very glad to be here. I'm very glad to speak to you today about, together with Jennifer, about best practice and, well, I would say the worst practice, because I wanted to say about our program, which was unfortunately the failure in Poland. I represent the Institute of Oncology, and there is no smoking cessation program. However, we know that apart from the location or and the stage of the tumor, the abstinence from smoking is considered to be the strongest predictor of cancer survivals in patients who ever smoking. So what are the benefits of quitting smoking after cancer diagnosis? This is the better survival results, and quitting smoking can lower the risk of death by 30 to 40%. The reduction of the risk of the recurrence and the next primary cancer, the reduction of the risk of complication of anti-cancer treatment, and increase, which is very important, the increased response to both chemo and radiation therapy, and as well immunotherapy. And self-assess the quality of life is better among those who quit smoking, and they have less pain. And what in the last but not least is that the people who can do something for their health, they take a control. They feel that they have influence of the effects on the treatment of the anti-cancer treatment. So there are a lot of, and those benefits are well documented. They are well described in peer-reviewed literature. So there are a lot of arguments to do the good smoking cessation program for cancer centers. But in fact, in Central and Eastern Europe, those programs don't exist. Jennifer, can we show the next slide? So I did a small survey among in countries who were the part of the workshop on tobacco control and cessation, which was organized by our institute and the National Cancer Institute a few years ago. So I just asked people in Armenia, Georgia, Hungary, Kazakhstan, Kyrgyzstan, Lithuania, Poland, Macedonia, and Serbia. They are Central and Eastern European countries and this Asian part of Europe. So I asked them about the guidelines, if they exist on smoking cessation for oncological patients. I asked them about the quit smoking programs for those patients, if the literature exists on the barriers or for delivery smoking cessation advice, and finally about the personal opinion of tobacco control experts about these barriers. So the results was not very positive and very optimistic, because the guidelines existed only in Serbia. The quit smoking programs were implemented only in Poland and Hungary. There was no literature on oncologists and in those countries and smoking cessation. And the expert opinions, they were consistent with the literature findings, and they said that the main barriers were a lack of knowledge, lack of training, overloading with anti-cancer treatment, and cost of anti-smoking drugs, which are not reimbursed in all those countries. So we decided to, the next slide, please. So we decided to implement the program in Poland, in our National Institute. So before the implementation, we made the materials on benefits of quitting smoking for patients. We delivered the training for nurses. We wanted to make this program as simple as possible, because we know that the involvement of oncologists is not very high. They see, as I saw on the previous slide, a lot of barriers to implement the smoking cessation advice. So we wanted to make it as simple as possible. So we just ask patients in a hospital admission room if they smoke and if they if they want to quit. If they were active tobacco user and they wanted to quit, they were just supposed, the staff were supposed only to refer them to QuitLine, because the QuitLine in our institute exists since 1996. So And it works very smoothly. So they were supposed to refer them to QuitAid. If the tobacco user said, I don't want to quit, then the trained nurse on the hospital ward, provided the minimal intervention. And if in the result of minimal intervention, a patient decided to quit, they were supposed to be referred to QuitAid again. But next slide, please. But unfortunately, it didn't work very well. So we were able to identify some obstacles we didn't take into consideration before implementing the program, like low motivation among personnel. Unfortunately, they didn't get any additional finance because we didn't have any special grant. We just wanted to, we thought that everybody will be active and engaged in this very important topic and will do it. But unfortunately, because they didn't get any additional finance, they were not very active. They were overloaded, of course, with the other work. There is unfortunately high prevalence of smoking among nurses in Poland. So, and the program were based on nurses. So the motivation was not very high, and they were unfortunately not volunteers, but they were, designated by the chief of the ward. Another obstacles was the lack of e-documentation in our institute. So there were a lot of delays in sending patient documentation. Sometimes 1 month or even 2, which is absolutely too long period, because we know that this, teachable moment is very important. And when they are diagnosed with cancer, the motivation to quit smoking is the highest, but it's going down within the short period. So this time was very important. And those forms we got sometimes, as I said, even 1 month later. And we didn't provide, unfortunately, the constant education and motivation activities among personnel, which could be obstacle as well. And there is no medication reimbursed, and it's quite expensive. So for patients, that was as well the obstacle. So we tried to find a good program which works well, and we realized that in University of Virginia there is a program which is very successful and very good and well organized. So now, Jen, can you just tell about your program?
Thank you, Magdalena. So at the University of Virginia's Comprehensive Cancer Center, we have developed a tobacco program. The Surgeon General report in 2014 summarized a little recognized fact that Magdalena touched on earlier, was that smoking after a cancer diagnosis increases all-cause mortality, cancer-specific mortality, and second primary cancers. So it's really important for us to address this behavioral issue during this person's life to really help them kind of achieve that. This report came out, and this led to our Cancer Institute to really start looking at how we could provide better tobacco cessation options and resources for our patients. And we want to empower patients and their families to become a healthy tobacco-free patient and really increase their chances of survival and effectiveness of treatment. So the background of my program, in 2014, we started with one person doing 4 clinical hours a week, providing tobacco cessation and resources to patients. In 2017, we received a grant that was specifically for developing our tobacco treatment program and improving our tobacco resources within our cancer care. The grant helped cover our salaries, our office space, supplies for patients. We do quick kits and starter kits, which I'm going to touch a little bit more on later, for patients to help them on their journey. With the support of the grant and our cancer center, we now have 2 full-time certified tobacco treatment specialists offering up to 80 clinical hours per week of services for patients. And so we have been able to expand immensely with the help of the grant. When developing the program, we took careful consideration into how we could integrate into the current workflows for the providers and the staff, because we all know that all staff and providers that work in the medical field are already extremely busy and trying to accomplish so many things in short periods of time. We conducted staff interviews and observed existing workflows just to make sure that with all the moving parts within the cancer center that we would be able to integrate easily into those workflows without creating any significant amount of work, and to make sure that that workflow remained a process that was easy for staff to follow. Our program is now embedded in all of our electronic health records, our staff workflows, and our process of patient management. This is the current basic workflow for our tobacco treatment program. At every visit, patients are asked about their tobacco use. If they're identified as a current user, then we always encourage them to work on either reducing or quitting, and they're offered a chance for a referral for our program. We are an opt-in program, so patients do have to agree to become part of our program. This just kind of helps ensure that they're at least interested in learning more about what's out there, and then we use motivational interviewing to help encourage them to move forward. For patients who are identified as former smokers, we still ask about their tobacco use at every visit just due to the high relapse of nicotine dependence. There's different pathways in our system for staff to enter their referrals due to the permissions for different positions. A licensed provider versus, a rooming staff, they have different permissions in our systems. And so we've worked really hard to identify the best pathway for them and then provide them with education on how to achieve placing that referral the proper way in our system. Once a referral is placed, it goes to our scheduling team, who reaches out to the patient to schedule the initial visit, which can be done in 3 different ways. We do initial visits in person, telephone, or a web-based video program. This really helps remove the barriers for the patient. Our catchment area is our entire state and some of our neighboring states. So transportation to our facility could be a barrier, and we want to eliminate that, especially if it's a financial restriction due to the cost of transportation. Once an initial visit is scheduled, then as a tobacco treatment specialist, it comes to us and we review their chart and reach out to the patient, view the appropriate scheduled visit type. At the initial visit, then we work with the patient. We talk about tobacco use history, current use, previous quit attempts, medications that are out there, and then we help them start to develop a plan. Each patient is triaged when they come into our program. So we have 3 different levels in which we provide services. We have a low level, which provides one initial visit to the patient. And that just means the patient's probably not interested in actively working on cessation and wanted to gather information. The second level is our moderate level. We provide 4 to 5 sessions for the patient. They're interested in quitting and working on it, but there's no urgency to do it right away. And then we have our highs, who are interested in quitting but have a very strong urgency to complete or quit smoking because they have a stem cell transplant coming up, a surgery, or a specific type of chemotherapy that can definitely be impeded by tobacco use. At each of our sessions, we use motivational interviewing to help keep the patient moving in the forward direction, answer questions, help them overcome any barriers that they have as well. Once the patient has completed active treatment, we place them into a long-term follow-up, which just means that we reach out at 3 months, 6 months, and 12 months after their active treatment, because that's the period of time when relapse is the highest. So we reach out, gather information for our program, but also continue to provide them support and relapse prevention techniques to keep them on the positive side of their quit. We also work with other family members in the household, as we find that it's extremely important to provide that support. So if a patient is participating in our program, their family member is able to participate free as well to help them achieve the goal of quitting, to create a healthier environment, reduce the chance of relapse, and promote healthy lifestyles for all family members. The family members can do their sessions together or separate. We really do that on a case-by-case basis, depending on what's going to be most comfortable and how the patient wants to share and go on their process. For our program, we strongly encourage the use of using tobacco cessation medications. Studies support that it does help increase chances of success, but it also decreases the chance of relapse, which is very important since the relapse rate for tobacco dependence is so high. There are 7 FDA medications that are approved for the U.S. Food and Drug Administration that we follow, and we only follow with these ones since they're the only ones that are approved. With the nicotine replacement therapies, we do recommend doing a combination therapy as it does increase the chances of success. So using the patches, which is a long-term, slow-relieving medication, with one of the quicker relieving medications, such as the nicotine gum, lozenges, inhaler, or nasal spray. We also recommend doing combination therapy with bupropion as well, as that does significantly increase the chances of success. The only medication that we don't recommend using combination therapy initially is the varenicline, since it is a partial antagonist. We will, if a patient is doing really well with the varenicline and just seems to be stuck quitting their last 3 to 4 cigarettes, then on a case-by-case basis, we do talk about introducing a quick relieving nicotine replacement therapy with that to really help them achieve that goal of quitting completely. We provide education to our patients. Every patient that enters the program gets a start or quit kit, which includes all of our education, our worksheets, our family support documents, and it also includes a coloring book and colored pencils, cinnamon candy, fidget spinners, some suckers, just some small things to provide to the patient to help them start their quit journey and provide them with some additional resources of what they can do instead of smoking to keep their hand and their mind distracted. 2 of the worksheets that we find extremely important are the pack tracks and the trigger worksheet. These are great to really help a patient get started on their journey. The pack tracks are for them to start tracking their daily smoking, what time they smoke, what activities they're doing that leads to their smoking, how do they feel, and their need for the tobacco. This allows a patient to truly understand what their smoking pattern is, because developing a quit plan is a very individual process. So we really need to know exactly what's happening with that specific patient. Why are they smoking? What are their major triggers? What are their favorite cigarettes during the day? So we can help them address those triggers on their quit journey, as that behavioral trigger will still lead to a craving, even if we're meeting the physical need for their nicotine. Once again, we provide the family support for patients who have family members who smoke and family members who don't smoke. So we provide ways that the family members can support somebody while they're quitting, so that it helps provide a more positive environment for the patient. We also provide starter kits if insurance will not cover the cost of nicotine replacement therapies. Here in the US, our nicotine replacement therapies are over the counter, and then the varenicline, the bupropion are a prescription medications. We can't help with those ones, but if they want to go with the nicotine replacement therapies, the patch, the gum, the lozenges, when we have funding, we provide them with the first month's supply of patches and some gum or lozenges to help them get started. We have found that this removes the barrier of the initial financial costs for patients. It allows them to try the products to build the confidence in them. And then once they're using the products and they've really reduced their tobacco use, then we can help them continue moving on, because they'll have more financial supports because they're not spending the money on cigarettes anymore and have the ability to do so. And we do have some insurance coverage here in the US that covers the nicotine replacement therapies, Medicaid, and some private insurances. Medicare does not cover any of the over-the-counter products. So they're the patients that if they want to use those, they're the patients that we're helping, are the patients that don't have insurance. Just trying to remove barriers and create more success. So our progress to date, these is 2 different ones. We have one, the end of treatment is the progress of people who have reduced or quit when active treatment ends. And then the blue one is our long-term follow-up, and that's for patients who have completed the full 12 months, the 3, the 6, the 12-month follow-up, and what their success rates are. At the end of active treatment, we have about a 71% chance success rate, and we count that as anybody who's reduced by 50% or more, all the way up to quitting. And at the end of active treatment, it's 77%. We like to look at that as the long-term follow-up is a positive support for these patients. The accountability that they feel with us following up with them does increase their chances of staying quit, and it also increases the chance that they were almost quit when they finish of completely quitting by the time we finish that 12-month follow-up. Some of the best decisions that we made with our program, as I discussed in the previous slide, was the utilization of process mapping to identify the current workflow, bottlenecks in service, and what barriers we had to overcome to truly integrate our program into the workflow and to the processes at our cancer center. It was a very tedious program that led to lots of questions, looking at different things, working really hard with our information technology department to make sure that all of our notes and workflows and flow sheets were in the system, that everybody had access to them, and that we can systematically integrate our program with everything else. We have now created our first draft of our tobacco treatment manual, which provides a step-by-step process of how our program runs, how we document in our system. And it just is a way to provide future training for people, as we hope, of course, to continue to grow and expand and make the process very systematic, very consistent. And that way, whatever services we're providing, it's going to be consistent throughout and not based on one person, but based on how to properly do everything and be able to do it with, even if we just suddenly went away. The two other best decisions that we made was streamlining the process for patients to get help with nicotine replacement therapies or other cessation medications. We partnered with our pharmacy medication assistance team. This is a team at our program, at our cancer center, at our health system, that helps patients with prior authorizations, linking them to different medication assistance programs if needed. And then, of course, with the help of our starter kits for patients that can't afford it or don't have insurance coverage to do so. As Magdalena stated earlier, the access to medication is very important. If patients don't have a way to help them quit, they're going to continue to struggle. The chance of successful cessation with cold turkey quitting without medication or counseling is only 5 to 15% at the highest. And so that was a big thing that we really wanted to overcome. We also found it's really important to understand your metrics, your system, your workflows, to make sure that the information that you are gathering is going to be able to provide you with sound data to be able to grow the program, show success, because of course everybody wants to have successful programs, and we wanted to make sure that we were able to document that and be able to grow with that. So part of our integration process was, how are we going to evaluate our program and making sure that we had those processes in place. And don't start big, start small, start with a pilot program. We started with one disease team and allowed it to grow from there, which was great because we got to learn where our barriers were, where our missteps were, and how we could overcome those. Magdalena?
Okay. Okay, thank you. I believe that all people find this program very interesting and very successful. I look at your results, and I just looked at our results described in the Journal of Oncology, and our results were a little bit lower, but still I think it's very impressive, because it was like 25% quit completely and 40% changed the habit and decreased substantially the smoking. So it's still very worth to continue it. However, we need some changes just to have an access to more patients. So lessons we learned from this fantastic UVA program is that we should at first talk to personnel on how to integrate and implement the program within their current workflow. We just cannot just designate people and expect that they will do it. because we need to understand how they work daily, and we should integrate this program with this work. We need some grant, I think, because it helps a lot. We should get the anti-tobacco medications. We cannot. I think we cannot count that the system changed in Poland, and we will have the anti-tobacco medication reimbursed in the short period. But we can just get. We can just try to get the medications from the pharmaceutical industry. What was very interesting was as well these family support activities. You introduced the program, and we think it's very important. And definitely we should not rely only on QuitLine, but we should as well create the smoking cessation unit within our institute, and introduce this opt-out system for our patients. So I think that's all. We learned a lot from your program, and I hope that in a very soon future we'll be able to implement this program with our trust team. Okay, so thank you very much.
Thank you very much, Magdalena and Jennifer. I'll now will introduce the next speaker. And just I want to remind everyone, if you have questions already, you can start typing them in the Q&A box. If you feel free, you can already start addressing them. We'll have plenty of time for Q&A later. I have a set of questions already. The next presenter is Dr. Melissa Little, who's Associate Professor of Public Health Sciences and a member in Cancer Control and Population Health Research in the Cancer Center at the University of Virginia also. And she will present her work developing QuitAid, a pharmacist-delivered tobacco cessation intervention based on medication therapy management approach to reduce tobacco use disparities in high-risk communities. So that's particularly important because we often see that we seem to have more success with higher income, but higher risk and lower income combinations are definitely more problems. And she will also present information about a study which sought to examine facilitators and barriers to translating QuitAid interventions and a family-delivered smoking cessation program developed in the United States and that was implemented in Poland. And that was part of a collaborative work with Dr. Paweł Kodasz, who's with the Cancer Epidemiology and Primary Prevention Department at the Maria Skłodowska-Curie National Research Institute of Oncology in Poland. He could unfortunately not join us, so he had to cancel last minute, but she will address some of that work. Melissa, the floor is yours.
I think that Melissa may have dropped out for a second, so she may be having internet issues. So we'll just give her a minute to rejoin. You're muted, Laurent.
Maybe while we give her a minute to rejoin, is it okay if I ask a question?
Yeah, and I note that also Jennifer, it looks like she dropped, so they may be having internet issues in the same place. So as long as your question's for Magdalena, we can go for it.
Yes, I do have. So I'll start. Magdalena, if you understood correctly, you stated that that your results were a little bit lower than UVA's. If I understand correctly, you made a statement towards the end of your presentation. And if that is the case, what do you think this is caused by? If you implemented a similar program, was it based cultural research? Was it a resource were there resource constraints? What do you think I guess I suspect you were saying that the success rate in quit attempts were lower, right? But if you could expand on that.
Yeah, I think they were a little bit lower because of the reimbursement of drugs. In this UVA program, the patients, they got drugs for free. And in Poland, they had to buy themselves. I think it can be one of the reason that the quit rates were a little bit lower. I cannot hear you, Laura. Okay.
Great. Thank you. And sorry, Melissa and Jennifer, we noticed you would drop for a minute. So I took advantage to ask a question to Magdalena, but we'll go straight into the next presentation, and we'll have time for Q&A later. Melissa, please go ahead. The floor is yours.
Thank you. Sorry about that. It must have been a UVA system-wide email or internet issue. Good afternoon or good morning, depending on where you're at. Today, I'm going to share some of the research I've been doing with rural smokers in the US, specifically in Appalachia. And then I'm going to talk a little bit about how we're translating this research into Poland. So in the United States, smoking rates are highest in regions of Appalachia. In fact, in this region, the smoking rate lags over 30 years behind the rest of the country. Smokers in this region are more likely to start earlier in life, smoke on a daily basis, and smoke in excess of 15 cigarettes per day. And they also have poor cessation-related outcomes. And as a result, they're disproportionately affected by cancer mortality. For example, rural smokers have an 18 to 20% higher risk of lung cancer compared to people living in urban areas. So the good news is that nicotine replacement therapy does increase the rate of quitting by 50 to 60%. Unfortunately, outside of research trials, we know that larger population-based studies have documented that a third of smokers believe that pharmacotherapy would be of either little help or actually reduce their chances of successfully quitting. And so when NRT is used in a quit attempt, smokers often do not use the recommended dose or duration for the medication, which reduces the effectiveness. We also know that cost is a big barrier for many low-income and rural smokers. So one avenue that we've thought about is, what about medication adherence interventions? How could these interventions increase adherence to NRT? So we looked at what's been previously done, and there is some available evidence that medication adherence interventions work for smoking cessation. However, in a recent meta-analysis, interventions only led to a small improvement in adherence and long-term smoking cessation rates. And the evidence was of low certainty, which means that we still need more research in this area. Further complicating the issue, in the United States, the national guidelines for treating tobacco dependence recommend that all clinicians engage patients through the Ask, Advise, Connect model. So they ask anybody who comes in to see them if they're smoking, advise them to quit or cut down, and then connect them to support. Unfortunately, in rural areas, this is a big barrier just because they have a critical shortage of primary care providers in these regions. So in the US, 20% of Americans live in rural areas, but only 10% of physicians practice there. And so we've decided as a team that we're really going to look elsewhere in the community to find somebody like a public health expert to connect smokers to existing services. And so what we've kind of settled on is community pharmacists. So despite the shortage of medical professionals in the United States, specifically rural areas, over 91% of Americans live within 5 miles of a community pharmacy. And the number of independent pharmacies has increased over the past decade by 12% in the US. So as a result, there's been this growing movement to train pharmacists to provide smoking cessation services. One, they have centralized placement in the community. 2, they have clinical expertise. And 3, they have a lot of interactions with patients on a daily basis. So people are constantly coming in for prescription medications. Sometimes they're coming in just to get a drink or a snack. So we thought this was great, but there's also barriers still. So while many pharmacists want to embrace health promotion as part of their professional identity, they often limit these activities in lieu of maximizing medication dispensation, right? So medication dispensation is where there's clear reimbursement for their services. So we feel that in order for pharmacists to be able to provide smoking cessation, there needs to be a way to reimburse them for these services. And we kind of stumbled upon this approach called medication therapy management. And this was developed to allow pharmacists to receive compensation for providing medication expertise for other chronic diseases such as diabetes and hypertension. And so this is already widely implemented across the US. There's standard documentation and billing systems associated with this. And we thought this is a great avenue to be able to reimburse pharmacists. Unfortunately, despite the fact that tobacco is a major risk factor for many diseases, pharmacist-delivered MTM for smoking cessation has not yet been developed or approved. And so we kind of thought that would be a great area for us to start. So we developed an MTM for smoking cessation called QuitAid. So this QuitAid program was based on a medication adherence intervention that had been shown to be efficacious in a quit line setting, but also incorporated elements of medication therapy management, really focusing on medication adherence. And so the intervention addresses perceptions about NRT. So in this study, we're focusing on nicotine replacement therapy. So what are the motivation and the self-efficacy and the beliefs about using NRT to help you quit? Do you believe that it's going to harm you? It's causing you to have a greater dependence on nicotine. And what are the practicalities of using NRT? So do you forget to use it? Do you need reminders? And so the intervention kind of addresses these things. There's one in-person coaching session with a participant at their local pharmacy, a check-in call 48 hours later, and then 4 coaching sessions delivered telephonically over the course of 4 weeks. And so, yes.
Could I ask you a clarifying question quickly? I'm sorry to interrupt.
Yes.
But what is excuse my ignorance, what is MT?
No, yes, MTM is medication therapy management. And so it's, and in other countries, it's called comprehensive medication management. And so, yeah.
Okay. It's clear now. Thank
call
you.
things differently. Yes. And so, so we decided to try to do a pilot feasibility study in a rural community pharmacy. And so, our outcome was just to see if people were amenable to this intervention, they would sign up. If the pharmacist felt that they could deliver this, people were engaged in the treatment. So we worked with one community pharmacy and we recruited 24 smokers from a rural Appalachian region of the US. And we did a factorial experiment to test alone and in combination these 3 treatments. So everybody received at least 4 weeks of NRT. Some people also received 8 weeks of NRT. Everyone always received 4 weeks of the patch, I should say. And so then some people also received 4 weeks of the gum plus patch or 8 weeks of the gum plus patch. And then some people received this smokers. So 2/3 of our participants were directly referred by their community pharmacists, which we thought was really great because reach is often an issue. We were able to recruit our sample in 3 months, which was really exciting. And what was really interesting was that we had reached people who reported, so all 24 people in our study reported that they had not sought any behavioral smoking cessation support in the past 12 months. So these aren't people who are calling quit lines or signing up for smoke-free texts or doing any of those sorts of behavioral counseling approaches. And we found that participants were also very positive about their community pharmacist. There was a high level of trust. And so we think that could have helped explain why we had such success in recruitment. So we had 52 people who, so 39 people expressed interest. 90% of them were screened and eligible to participate. 69% were enrolled, and 92% of them were followed to a 3-month follow-up. So we felt that was a high level of retention in the study. We also found that the interventions were well attended. So almost all of the MTM sessions were received, and the majority of the patch was used. Less of the gum was used, but that was an adjunct treatment, so we weren't surprised that it was lower, given that that wasn't the primary treatment. We also found that 32% of participants reported quitting at the follow-up, and 89% reported setting a quit date. And we don't, in this study, I'm not looking at individual differences between the treatments, because again, this was just a feasibility study, and we weren't really powered to look at differences. In terms of satisfaction, there was a high level of satisfaction with the QuitAid MTM intervention. So most participants believed that their pharmacist was knowledgeable about the use of NRT and its side effects. They were comfortable talking to their pharmacist about their quit attempt. Only a quarter of them found it difficult to meet with their pharmacist, and nobody felt that there were too many sessions. We also found an overall high level of satisfaction with the program itself overall. And so 89% of participants stated that they were satisfied with the program, would recommend the program to a friend or family member, and believe that the program made it easy to use the patch. And additionally, 94% felt that the program helped them cut down or quit, which we felt really happy about. Our pharmacists also reported satisfaction, so they felt that the program, the QuitAid intervention, was straightforward, easy to implement, and well received by study participants. One of our pharmacists said that the process of recruiting and enrolling participants was easy. The intervention guides were clear and easy to follow, and our entire staff was able to contribute in their own way to the success of the project. And so where do we go from here? So as you might recall me mentioning earlier, none of the participants who enrolled in this study had utilized any behavioral smoking cessation services in the year prior to enrolling in our study. So we actually feel that community pharmacists are ideally situated in rural areas to not only enhance cessation through a sustainable MTM approach for smoking cessation, but also facilitate utilization of existing publicly available services using an Ask, Advise, Connect model. And so along these lines, we were recently funded to conduct a large randomized control trial testing effectorial design among rural smokers with these treatment components. And so, and this grant is funded by the National Cancer Institute in the United States. And so participants will receive text messaging, yes or no, nicotine replacement therapy, patch or gum, quitline treatment, yes or no, and then the pharmacist-delivered intervention, yes or no. And our goal is to start recruiting in the spring. So for this, I'd like to thank my collaborators, because it really does take a village to do these studies. And then just briefly, I wanted to just talk about our plans for how we're going to translate what we've done in the US with our my collaborators in Poland. And so in Poland, despite declines in smoking over the past 30 years, nearly a quarter of adults continue to smoke cigarettes. And Polish women are less likely to quit compared to men. And this is even more pronounced in rural areas. And so as a result, women experience higher incidence of tobacco-related death and disability in Poland. And so we feel like there's a need to expand tobacco control efforts to reach these vulnerable individuals, namely women and women living in rural regions. And so, so we thought, what about translating QuitAid? So similar to the US, there's a well-developed network of pharmacists in Poland. And similarly, also, the number of pharmacists has grown in recent years in Poland. So the community pharmacists could be ideally situated also in these underserved areas of Poland to enhance smoking cessation support. There's also been studies showing that individuals are willing to receive pharmacy consultations surrounding medication management in Poland. And 79% of community pharmacists in Poland believe they're qualified to provide tobacco cessation services. So right now we're working on developing a pilot study similar to what we did in the US. So we're seeking some funding to kind of roll out a small scale study to test whether this would work in Poland. And ultimately, the goal is to disseminate this project in Poland and reach these vulnerable populations. That's all I have.
Thank you very much, Melissa. And so I have a number of questions, but I also encourage them to send directly to me, but I also encourage any of the attendees to type them in the Q&A. So I'll start with the questions that I have that were sent to me. So the very first one was about what were the first steps to form that collaboration? I think you mentioned, Magdalena, that you had heard about UVA's program, but how did that happen to make it happen and to make a reality, given that we have a number of partners in low and middle income countries who would be interested in that type of approach? So what are the first steps to make it happen and make this collaboration a reality?
Well, I think we just signed the memorandum of understanding with the UVA, our institute, and that was the first step.
And we and our colleague Pavel, who's not here today, he was actually doing a Fulbright fellowship here at UVA. So he had applied to do a fellowship here, which I encourage all individuals from low and middle income countries to do, because he was able to be here working with us, and he worked with Jennifer to learn about the quit line or the quit treatment, the smoking cessation treatment. He worked with me on some of my research. But I would also suggest, just as being somebody who is also really interested in working internationally, but I don't know how to start that either. If somebody is interested in something that somebody's doing and they see a publication and they're like, that could be really interesting here, reach out. There's corresponding authors, emails on all those publications. And I have a feeling most people would be receptive to that.
So you're saying, so for those, because that will be, well, before I ask a follow-up question, Jennifer, do you have anything to add to this?
No, we met Paulo through the fellowship, and once he introduced and read through our program, I think he visited another university when he was here in the US as well, and was able to get kind of a collaboration of what we're doing over here. Of course, was inspired by it and wanted to take it home with him.
Great, and I suspect those, who will, we have a limited number of people, but a number of people will watch and do watch the webinar through YouTube and our other channels. So if they wanted to follow up with you, so that would be the best thing to do, would be to just contact you and start initiating a communication process. Great. I already asked you, that was the question about the lower results. I was struck by the statement you made, Melissa, about Polish women being less successful in quitting attempts. And I think this is very important to a lot of the, it's very relevant to a lot of the obligations that countries have to protect a woman's rights to health. And the issue of resources has been, lack of resources or when the treatments are not financially covered, that's a major issue. So do you see that argument as protecting women's rights in this context of cessation, which I don't think it's an argument that's often made? Do you think that would be a valuable argument and to make in order to secure resources for cessation treatment?
I think so. I am, newer into the research on smoking in Poland. So Magdalena, please jump in. But I recently had done a lit review, and I had talked to Magdalena and Pavel about this before, about how lung cancer rates are decreasing among men in Poland, but they're still increasing among women. And I was struck by this huge disparity that I felt like definitely needed to be addressed. And so I was trying to understand context behind that. And one of the things I came upon was that men still have a higher smoking rate in Poland, but women are less likely to quit. And so as a result, their lung cancer rates aren't decreasing like men's are. So men, the rate has a steeper slope, and so their lung cancer rates are going down and women's aren't. And I don't know, Magdalena, do you want to jump in?
Yeah, we are the country with a very, very high level of smoking in 80s. It was like 80% of men smoking. And because of the good social climate at the beginning of 90s, they really quit smoking and the rate decreased. So now every third man smoked in Poland. But with women, it's a little bit more complicated because the smoking prevalence is quite stable. I mean, they didn't quit. So it's around 20% for all the time. So that's why, as Melissa said, we have in Poland, the breast cancer is the highest if we think about the morbidity. But unfortunately, the lung cancer is the killer number one of Polish women. But I think it must take a time for our government to understand that we should put special attention to women, and we should put very well-tailored programs for women because they don't quit. So, yeah, we are trying, the institute, like our institute or some non-governmental organization, we're trying to put some attention to women, but it's very complicated because we need a real the governmental approach to implement the tailor for programs for women.
Right. So something I recommend is to link with us and other organizations who use human rights treaties. And particularly for in Poland, for example, is due to report on the Convention Against All Discrimination Against Women, might be an opportunity to address that in that report and to try to secure more resources and raise more attention to that challenge, which I'm sure is not just specific to Poland. I have a number of other questions that have been there. So if, unless you have something else to add to this, I'll move on to the next one. Jennifer, you mentioned some documents or briefs that will, and I just wanted to know if those will be available. I'm not using the right term you used exactly, but you mentioned about having some type of document, policy, not policy document, but like some materials that were going to be available.
We provide, are you talking about maybe patient education materials that we provide to patients?
Yes, so you mentioned a specific, I don't know if you know, I should have written down the exact word you used. I don't know if you use report, but of like a manual or a guideline or
Oh,
some.
we developed a tobacco treatment manual. We can
That's what I
share
meant.
that. It's still like in a draft phase. So, and of course, we all know health systems change and grow at a continuous rate. So it's a living document. But I'm sure we would be happy to share that. It's very specific to our electronic health medical record process, because it kind of goes into detail, but it's also enough to provide some guidelines on what we're doing, how we're doing it, what we're providing to patients. It's all included in there. And so, yeah, we can take a look at ours. We might want to clean it up a little bit, and then I'd be happy to send it over to you guys to be able to share with others.
Great, wonderful. Then in the context of the limiting barriers, you often mention the cost and the cost of the medications. And so I have two questions. So obviously some medications, for example, varenicline, for example, can be expensive. So I had a question, something that was not mentioned, I understand had been used in Poland for a while, was Cessation. And what are your thoughts on that? And you see that as, what's the availability in Poland? And I understand that other countries have looked at that and potentially going through regulatory frameworks to make it available. Do you see that as a good option for for low middle income countries? I understand, I believe there was a WHO report that was going to look at it, at the effectiveness, because that was putting questions. And I'd heard people, particularly from high income countries, said, you know, maybe we feel uncomfortable saying recommended for a low income country if we don't have it for a high income country. So I want to have your thoughts on that. Then Jennifer, you also commented something about varenicline was not one of the things that you were always prescribing, if you could expand a little bit more on that. Sorry, I put a few questions in one. I'll give the floor to any of you to answer, or all of you, one after the other though.
Well, yeah, Cessation is in Poland, available. And as I know, there are more and more countries that have Cessation available, for example, Western Europe. And I know that there were published results of this ORCA trial in the United States. So I hope that one day, I hope soon, you will have it's available as well. Yeah, but it's only one from different drugs, and most of them are much more expensive. Cessation is cheap. Yeah, and it's the most popular among Polish people, but it's still something which they have to buy by themselves.
So it's still, it's absolutely critical, in my opinion. I would suspect you would agree that if a government allows the sale of a lethal and addictive product like cigarettes, they also have an obligation to help the people who smoke quit. I think it's an obligation that those countries have towards their citizens and protecting their right to health. But Melissa and Jennifer, anything to add on that specific topic?
So just with the varenicline, we do recommend that. The two pathways we recommend is either the combination therapy with the nicotine replacements or the varenicline. We just don't usually recommend doing the varenicline with the nicotine replacement therapy, since the varenicline is a partial antagonist and does block most of those nicotine receptors. But we're not completely closed off to the idea, because there are more and more studies that are starting to support that the addition of adding one of the nicotine replacement quick relievers with the varenicline does help support more success. So I'm sorry if I misspoke on that. The pathway that we do recommend the most is either the combination therapy with the nicotine replacements or the varenicline.
Great. Melissa, did you have anything to add?
I was just going to say, Magdalena and I are trying to work on QuitAid Poland, and one thing we talked about in the US, NRT is available everywhere. But in Poland, Cessation is available. So it's not so much about the medication, it's about what's available, what people have access to, what people can adhere to. And so, I think the intervention could work across. It's what's going to be best for people. But I completely agree with you that the cost of pharmacotherapy needs to be addressed. And the issue of, generic versus prescription and the benefits, and even people who have prescription benefits, it doesn't always cover NRT, because then there's the generic version, which isn't affordable. So I know we have 1 minute left and I will get off my soapbox, but it's definitely an issue that I think needs to be addressed worldwide.
Well, yes, indeed, wonderful presentations, and I have quite a number of other questions, and including how, how was it that the pharmacists in the presentation, Melissa, were so effective at recruiting patients, but unfortunately, and recruiting smokers who were interested in quitting. Unfortunately, we're at the time, but I want to thank you for joining us today and for those presentations. And I want to encourage all of the audience and those who will watch the webinar and the recording of the webinar to stay tuned for the upcoming webinars that we'll be doing. There's a next one on December 15th, which is a town hall one, but we'll be doing some other ones. So, for example, we are doing probably one on the 21st of this month on linking the tobacco control to the upcoming UN treaty to end plastic pollution. This is a treaty that will start being negotiated at the end of this month, and that could enter into force in 2025. And it's a unique opportunity to address tobacco products and all the plastics that are associated with tobacco products. And that includes cigarette filters, which are made out of plastic, do not biodegrade, are highly toxic when discarded, and don't even really protect the health of the people who smoke. So that could be quite interesting, and we'll share more information when that's available. So again, thank you very much to all of you for joining us today. And I'm sorry that I was not able to address all of the questions that I received. Thank you very much, and stay tuned and keep in touch. Bye-bye.